Welcome to this webinar, which is organized by ISAR Haryana. This is Up to Dates with Updates, episode 4, where we have two articles being discussed, one by Dr. Laxmi Goel and the other by Dr. Rahul Sen. This is a activity which is organized by ISAR Haryana, and the chairperson for this Haryana chapter, ISAR, is Dr. Jyoti Malik. Thank you, ma'am, for organizing such wonderful programs. And I now hand it over to you to start the webinar.
Thank you so much. Thank you, Dr. Deepika. Thank you, Jackson Paul. And welcome to Up to Date with Updates, episode 4. And today we invite you for this discussion on two articles. And this is actually with the blessings and support of our think tanks of ISAR, Dr. Ameet Patki, sir, who's the president, Dr. Nandita Palshetkar, the past president, President-elect Dr. Sunita Tandulwadkar, ma'am, Vice President Dr. Madhuri Patil, Vice President Dr. Sujata Kar, Secretary General Dr. Asha, Baxi, ma'am, and the two chairperson, two embryologists, one, the chairman Dr. Charudutt Joshi and Vice Chairman Dr. Keshav. So we have these think tanks, and one of the think tanks does join us for this discussion and for guiding us. And this time we have Dr. Sujata Kar as our expert for these two articles. And we have our team ISAR Haryana, the Secretary Dr. Meenu, Clinical Secretary Dr. Manju, and Treasurer Dr. Laxmi Goel, who are constantly involving in these activities and bringing to you these newer webinars. So for today, we have the first article. Do we have CV of Dr. Laxmi? Yeah, so Dr. Laxmi Goel is our treasurer, as already told, that she is the treasurer of ISAR Haryana, and she's an IVF consultant at Cloud9 Fertility, Cloud9 Hospital, Faridabad, and she is a fellow in the reproductive medicine. So she would be talking on an article of evolution of biotechnological advances and regenerative therapies for endometrial disorders, a systematic review. So over to Dr. Laxmi, and then we have the second article following your talk, your presentation. So that would be by Dr. Rahul. So I'll take his CV maybe after Dr. Laxmi's talk. Over to Dr. Laxmi. Thank you.
Thank you, Dr. Jyoti. Thank you, Dr. Deepika. Thank you, Jackson Pal, for this initiative. So we are going to discuss this article, which is on the evolution of the biotechnological advances and regenerative therapies for endometrial disorder. It's a systematic review, and this review has been it is a collection of from many centers. The review has been done from Spain, Italy, USA, and we will discuss about the about introduction, the methods, the protocol and the registration part, study selection and eligibility criteria, search strategy, data extraction and synthesis of results. In the results, we'll see the search results, regenerative endometrial therapies, systematic summary of the literature, state-of-the-art applications of regenerative therapies in the endometrium, and then finally the discussion on the conventional hysteroscopy and pharmacology, precursor therapies, the evolution of endometrial regeneration, new perspectives, what does the future hold, and the limitations, and finally the conclusion. Now, if we see the abstract of this article, the background says the establishment and the maintenance of pregnancy depend on the endometrial competence. Asherman syndrome and intrauterine adhesions or endometrial atrophy and thin endometrium can either originate autonomously or arise as a result of conditions such as endometritis or congenital hypoplasia or medical interventions like surgeries, hormonal therapies, uterine curettage or radiotherapy. Affected patients may present an altered or inadequate endometrial lining that hinders the embryo implantation and increases the risk of poor pregnancy outcomes and miscarriage. So day to day, we see that in humans, Asherman syndrome, intrauterine adhesions, and endometrial atrophy or thin endometrium are mainly treated with surgeries or pharmacotherapy. However, the reported efficacy of these therapeutic approaches remain unclear. Thus, novel regenerative techniques utilizing the stem cells, growth factors, or tissue engineering have emerged to improve the reproductive outcomes. If we see that this review comprehensively summarizes the methodologies and outcomes of emerging biotechnologies like cellular, acellular, and bioengineering approaches to treat the human endometrial pathologies. Regenerative therapies derived from human tissues of blood, which were studied in preclinical models and clinical trials, are discussed in this article. So we'll see that between January 2000 and September 2023, all the studies which have been done has been included in these articles. And from a total of 4366 records identified, 164 studies were included for the systematic review. And due to heterogeneity in the study design and measured outcome parameters in both preclinical and clinical studies, the findings were evaluated quantitatively and qualitatively without meta-analysis. So we see that the groups using stem cell based treatments for endometrial pathologies commonly employed mesenchymal stem cells derived from the human bone marrow or umbilical cord. Alternatively, acellular therapies based on PRP or extracellular vesicles are gaining popularity. These are accompanied by the emergence of bioengineering strategies based on extracellular matrix, derived hydrogels, or synthetic biosimilars. So, what are the wider implications of this analysis? Therapies that promote endometrial proliferation, vascular development, and tissue repair may help restore the endometrial function and ultimately fertility. Based on the existing evidence, cost, accessibility, and availability of the therapies, we propose the development of triple hit regenerative strategies, potentially combining high-yield mesenchymal stem cells from bone marrow or umbilical cord with acellular treatment, PRP, possibly integrated in the ECM hydrogels. Advances in the biotechnologies together with insights from preclinical models will pave the way for developing personalized treatment regimens for patients with infertility, causing endometrial disorders. So this is a very beautiful graphical abstract which has been given. In this, we see the background, the precursor therapies for Asherman syndrome. The pathology is Asherman syndrome, intrauterine adhesions, endometrial atrophy or thin endometrium, and endometritis. This is a pathology. And till now, we do only surgeries or give pharmacological treatment in the form of estrogen, generally for this problem. And the objective of this review is to summarize the methodologies and outcomes of emerging biotechnologies like cellular, acellular, and bioengineering approaches to treat human endometrial pathologies. And in this particular review, from 2000 to 2023, 164 studies were screened out of 3970 studies, and they were divided into in vitro studies, in vivo studies, and the human studies. And the outcomes which were measured were the findings, because basically three therapies, the cellular, acellular, and the bioengineering, these three therapies were discussed, and the findings were in the form of endometrial thickness, cell proliferation, fibrosis, angiogenesis, and fertility. So these are the findings which will be discussed later on. So the human endometrium is the innermost mucosal layer of the uterus, which connects to the fallopian tubes and ovaries. This tissue, comprised mainly of stroma and uterine glands, is crucial for successful embryo implantation and adequate uterine function. In addition, the endometrial layer prevents the adhesion formation between the opposed walls of the myometrium, thereby maintaining the integrity of the uterine cavity. The cyclical endometrial remodeling and proliferation drive the hypothesis that a subset of somatic or adult endometrial stem cells are activated every menstrual cycle. And dysfunctional endogenous endometrial stem cell populations were related to certain gynecological disorders and conditions, including the Asherman syndrome, intrauterine adhesions, and therefore leads to thin endometrium, endometrial atrophy, and poor fertility outcomes. Pathologies that directly interfere with the endometrial lining, such as the Asherman syndrome and intrauterine adhesions, may provoke a refractory endometrium characterized by a lack of proliferation and abnormal thickness, which in turn causes infertility. The earliest report of curettage causing intrauterine adhesions and amenorrhea was in 1894. However, the term Asherman syndrome was only coined in 1950 when Dr. Asherman described 29 cases of secondary amenorrhea following intrauterine trauma. So, Asherman syndrome is characterized by the presence of intrauterine adhesions or endocervical adhesions with the consequent risk of hypomenorrhea or amenorrhea. The endometrial atrophy or thin endometrium is characterized by the endometrial thickness of less than 6 to 8 millimeters during the secretory phase, with no consensus among the various published studies. Endometrial thickness is measured by ultrasonography, as we all know, on the day of the HCG administration in IVF cycle, or when we have to start with the progesterone in the FED cycles. Hysteroscopy is the gold standard for intrauterine adhesion surgery, which aims to restore the uterine cavity size and shape, thus normalizing the endometrial function. Treatment options vary from adhesiolysis, using scissor, to electrocautery, laser ablation. However, these approaches have variable results and are often, we see that it is unsuccessful in severe cases. So, we will see how we can deal with these severe cases in this review. So, notably, therapies designed to improve endometrial thickness and ultimately reproductive performance were mainly tested in studies with small cohort and or with poor methodology. Further, conflicting outcomes for anatomical restoration and reproductive parameters were reported. Conventional hormone-based therapies involved high doses of estrogen, long-lasting secondary effects, and different routes of administration. Other therapies that targeted endometrial cellular receptors, example systemic HCG, GnRH, or growth hormone, blood flow enhancers like L-arginine, aspirin, sildenafil, pentoxifylline, nitroglycerin, or utilized biomimetic electrical stimulation did not consistently restore the uterine function or improve the reproductive outcomes. Due to ineffective the outcome with these therapies, emerging strategies that aim to change the current practices in reproductive medicines are based on new therapeutics and biotechnological advances. Cell therapy is defined as the transfer of autologous or allogenic cellular materials via injection or instillation or transplantation for medical purposes. So, these new studies have come which have used, they were followed by studies exploring strategies with mesenchymal stem cells derived from human menstrual blood, derived menstrual mesenchymal stem cells, and umbilical cord derived stem cells, among other cell sources. In 2013, non-invasive acellular therapies for endometrial regeneration were introduced with platelet-rich plasma, followed by microRNAs, extracellular vesicles, and other growth factors. So if we see that there have been, since 2000 to 2023, there were, these are the number of studies which were performed. In 2011, 2 studies were done for using cellular therapies, and then 2012, 2013. In 2023, 7 studies were done using cellular therapies, 18 studies in acellular therapies, and 6 with the bioengineering methods. In this review, we summarize the methodologies and main findings of the studies evaluating the endometrial repair and regeneration strategies based on stem cells, acellular components, and bioengineering, mainly these three approaches, which includes the cellular, acellular, and the bioengineering approaches. The growing interest in these new strategies contrasts with the stagnant landscape of conventional pharmacological treatments. We present both preclinical and clinical evidences to guide the design of future studies and facilitate the informed decision-making in patients undergoing infertility treatment with ART. So the method which was involved, protocol and registration. Protocol was reported in accordance with the PRISMA P, and the systematic review following the PRISMA 2020 guidelines. Study selection was anti-eligibility criteria. The population intervention comparison and outcome framework was used to define the eligibility criteria of this systematic review. Briefly, we screened the study population intervention to regenerate the endometrium comparison and outcome. Included original, rigorous, and accessible peer-reviewed full-text articles that reported the treatment of any acellular, cellular, or bioengineering approaches to treat the endometrial diseases and applied these regenerative treatments in preclinical and clinical studies. So these are the studies which were included using the database from PubMed and Embase. So total number of studies included for systematic review finally were 164. What were the results? Yeah. So results, there were, so it was divided into the in vitro studies, in vivo studies, and the clinical trials. So in vitro studies were the studies which are done outside. So the number in the circle indicates the number of studies. The peripheral PRPs, 5 studies were done, extracellular vesicles, 1 study, mesenchymal stem cell, 1 study, and there were different studies which were done in vitro. In vivo is the animal studies which was done, and the clinical trials which were done on the humans. So we see that bone marrow derived mesenchymal stem cells, peripheral PRPs, adipose derived mesenchymal stem cells, and then along with other therapies, they were sources of the human-based therapies used for preclinical studies and clinical trials for endometrial. Now we'll discuss each approach. First, we'll see the cellular therapies, then the acellular and the bioengineering. Amongst the cellular therapies, in 88 studies, the total of 88 studies were seen from the cellular therapies, which used cellular therapies for the endometrial regeneration. So in total of 88 studies, human mesenchymal stem cells were used for endometrial regeneration. Mesenchymal stem cells were obtained from the bone marrow in 17% of the 88. Endometrium mesenchymal stem cells from 10%, umbilical cord 40%, menstrual blood 8%, and alternative sources from 19%. So first we see the bone marrow derived stem cells. Bone marrow derived mesenchymal stem cells are multipotent hematopoietic cells derived from spongy tissues of bone marrow. To obtain these stem cells, marrow aspiration from the hip bone on the peripheral blood must be carried out, followed by the isolation of the cell population of interest. 15 studies were reported the use of bone marrow mesenchymal stem cells in the preclinical or clinical trials. Specifically, 2 studies employed in vitro models of Asherman syndrome or intrauterine adhesions, which also evaluated their regenerative potential in vivo. While one utilized commercial bone marrow mesenchymal stem cells, the other opted for heterogeneous cells, all of which remained in the preclinical testing. So we see that bone marrow derived stem cells in vivo studies and the clinical trials which were done. To 6 clinical trials employed local injection, intrauterine instillation, and delivery via collagen assembly carrier. Then if we come to the endometrial mesenchymal stem cells, they have been characterized as precursors for the epithelial or the stromal cells in the endometrium. Endometrial biopsy stands as the prevalent method for endometrial mesenchymal stem cells procurement. Endometrial mesenchymal stem cells based treatments were reported in 9 of the included studies, only 1 of which examined their effect in an in vitro model of Asherman syndrome or intrauterine adhesions. Now we come to the umbilical cord derived mesenchymal stem cells. Umbilical cord mesenchymal stem cells are multipotent stem cells that can differentiate into various cell types. The primary source of umbilical cord mesenchymal stem cells is generally the blood within the umbilical cord, a cord-like structure that connects a fetus to the placenta. However, the recent evidence shows that they can also be isolated from the Wharton's jelly, the connective tissue of the umbilical cord. Now we come to the menstrual blood derived mesenchymal stem cells. Menstrual blood-derived mesenchymal stem cells are multipotent stem cells that can be isolated from menstrual blood and have the ability to differentiate into endometrial epithelium or stromal cells. The notable advantages of these stem cells lies in the non-invasive collection approach from used tampons or menstrual cups. Among the 11 studies evaluating menstrual blood mesenchymal stem cells to treat Asherman's or intrauterine adhesions, 2 were in vitro studies. One of these studies used heterologous menstrual mesenchymal stem cells, while the other employed a commercial source. Other mesenchymal stem cells, alternatively reservoirs of mesenchymal stem cells, such as the placenta or adipose tissue, offer potential sources for acquiring the placental amniotic mesenchymal stem cells, embryonic stem cells, adipose tissue derived stem cells, or induced pluripotent stem cells. Numerous applications of these mesenchymal stem cells in regenerative medicines are currently being researched. Now, the placental amniotic mesenchymal stem cells, 2 groups tested heterologous human amniotic mesenchymal stem cells in vitro, and 9 rodent models were reported. While most of the studies did not include a carrier to control the amniotic membrane, amniotic mesenchymal stem cell distribution, cell retention was enhanced with the polyethylene glycol citrate co-N-isopropyl acrylamide in one of the Asherman's or intrauterine adhesion mouse model. So combined administration routes were used, including intravenous injection, local injection, or instillation alone. Therapies based on amniotic mesenchymal stem cells had not been progressed to clinical trials yet. Now, the embryonic stem cells were tested in 3 studies modeling Asherman syndrome or intrauterine adhesions in rodents. In rats, the endometrial damage was induced by wall rejection or scratching and treated with embryonic organoids by local instillation. In the mouse model, the damage induced by endometrial scratching was successfully reverted using embryonic stem cells. Therapy based on embryonic stem cells have not yet progressed to clinical trials. Adipose-derived mesenchymal stem cells were delivered in a human amniotic membrane-derived scaffold to treat the ethanol-induced uterine damage in a rat model of Asherman's or intrauterine adhesions. They have also been tested to clinically treat endometrial atrophy or thin endometrium. In both clinical trials, autologous adipose tissue-derived mesenchymal stem cells were administered locally without any carrier. Induced pluripotent stem cells. Finally, induced pluripotent stem cells were loaded into a bioprinted scaffold to revert Asherman's or intrauterine adhesions in a rat model. And there was 1 report of commercial mesenchymal stem cells with an unspecified source used to treat the LPS-induced endometritis in vitro. Therapies based on induced pluripotent stem cells have not progressed to clinical trials. Now, this was about the cellular therapies or the stem cell therapies. Now we come to the acellular therapies. Among the acellular therapies, we classified 80 reports of acellular therapies for endometrial disorders into 4 main categories. 50% of the studies were on PRP, and the 25% were on the EVs, that is the extracellular vesicles, including the exosomes and the microvesicles, miRNAs, 10% studies, and alternatives, 13%. Now we come on to PRP, platelet-rich plasma. PRP is a fraction of blood usually collected from the peripheral blood through the conventional vein puncture or sourced from the allogenic sources such as healthier donors or the umbilical cord blood after delivery. The PRP is easily obtained via the gradient density centrifugation and provides supraphysiological platelet concentration for clinical use. PRP is currently the leading acellular therapy to treat the endometrial pathologies, while 40 reports included in this review. Of the 6 studies testing PRP in vitro, half used PRP from a heterologous source. However, autologous PRP was more often employed than commercial PRPs. Now, this was on the PRPs. Then we have the extracellular vesicles. Extracellular vesicles are the heterogeneous cell-derived membranous structures comprising exosomes secreted by the endosomes or the microvesicles budding from the membrane. They are replete with proteins, lipids, nucleic acids, and metabolites that confer therapeutic properties. EVs can be isolated based on the size, surface charge, or immunoaffinity. Ultracentrifugation is currently considered the gold standard technique. Finally, there was no report of EV-based treatment on the endometrial pathologies and in humans. MicroRNAs are evolutionary conserved small non-coding single-stranded RNAs, generally 21 to 22 nucleotides length, that repress gene expression with translational inhibition or mRNA degradation. Typically, miRNAs achieve these regulatory effects by binding to specific recognition sites on target mRNAs via complementary base pairing. miRNAs participate in various cellular processes, including but not limited to aging and apoptosis, in addition to diverse signaling pathways. Alternative acellular therapies. During in vitro cell culture, stem cells release a myriad of growth factors and paracrine effectors into the medium. Thus, centrifugation of spent medium concentrates as interesting cocktail of biomolecules for use in regenerative medicines. Moreover, glycoproteins such as the granulocyte colony stimulating factor GCSF interact with the extracellular matrix of the stem cell niche, reducing the attachment of stem cells to the stroma and promoting their mobilization into the bloodstream. Now we come to the bioengineering tools. Extracellular matrix derived hydrogels. The use of bioengineering strategies offers the ability to sustain cells and or active ingredients of treatments at the target site, extending a favorable environment that improves the regeneration rate. Hydrogels derived from DCM designed to control treatment delivery and retain the characteristics of the native milieu are prominent bioengineering tools. 8 preclinical studies use DCM carriers to deliver endometrial treatments. Among these, one study delivered commercial estradiol loaded microspheres in an amniotic membrane derived hydrogels to treat the Asherman's or intrauterine adhesions in vitro. So, overview of the outcome measured. We see the gray, the purple, and the pink. The gray is the in vitro studies. We see that the outcomes were regeneration patterns and mRNA expression, gene expression, cell proliferation, which was studied in vitro, the fibrosis and the apoptosis. The purple ones were the animal studies, the in vivo studies. The outcomes were the regeneration patterns, angiogenesis, functional markers, endometrial thickness, how it increased, the gland concentration, and the immunotolerance, fertility, fibrosis, and cell proliferation. And in the clinical trials on humans, the outcome measured were endometrial thickness, how it increased after these using acellular techniques or cellular or bioengineering techniques, and the regeneration patterns, fibrosis, fertility, cell proliferation, and the menstrual changes. So these were the outcomes which were measured. So we see that now we come to the discussion part of it. The conventional therapies, despite there being no international consensus on what is considered an optimum endometrium, and a recent study suggesting that thin endometrium does not affect embryo transfer outcome, most groups agree that patients with a thin endometrium, that is less than 6 to 8 millimeter at the secretory phase, following adequate estrogen exposure, have poor reproductive outcomes. Specifically, patients with thin endometrium are reported to present lower implantation, clinical pregnancy, and live birth rates, coupled with higher risk of miscarriages. So conventional therapies, in these cases, additional pharmacotherapy with hormones, estrogen, blood flow enhancers is complemented to improve the reproductive performance. Estrogen therapy can be adjusted to higher dose, longer duration, or alternative administration routes. Notably, combining certain blood flow enhancers for at least 6 months proved to be beneficial. Many existing pharmacotherapy studies exhibited methodological flaws related to the study design and population, or had heterogeneous protocol for drug administration or patient management, leading to discrepancies on the therapeutic benefits. Now we come to the discussion on the cellular therapies. The first stem cell transplantation was reported in 1965 when Thomas and Epstein transplanted bone marrow mesenchymal stem cells to treat the acute leukemia. Mounting evidence from successful autologous or allogeneic mesenchymal stem cell treatments show regenerative functions of mesenchymal stem cells in several tissues. Since 2011, there have been 88 studies describing stem cell therapies based on bone marrow mesenchymal stem cells, endometrial mesenchymal stem cells, umbilical cord, or menstrual blood derived, and other mesenchymal stem cells to treat the anomaly pathologies. This elevated number of publications reflects the pressing clinical need to optimize efficacy of these therapies using well-designed randomized clinical trials. Among the mesenchymal stem cell therapies tested in humans, the most efficient were those derived from the bone marrow and the umbilical cord. Umbilical cord mesenchymal stem cells are collected non-invasively from the tissues typically discarded after delivery and have potent anti-inflammatory and immunosuppressive properties. Endometrial treatments with umbilical cord mesenchymal stem cells embedded in biomaterials were immunotolerated and sustained the in vivo responses for longer than umbilical cord mesenchymal stem cells alone, while there have been not been any reports of treatment with bone marrow mesenchymal stem cells embedded in hydrogels. Preclinical studies have shown that intrauterine administration of menstrual blood mesenchymal stem cells increase the animal thickness, angiogenic factors, and fertility rates, similar to umbilical cord or the bone marrow mesenchymal stem cells. Menstrual blood-derived mesenchymal stem cell therapy recently progressed to clinical testing and is promising due to non-invasive collection of the menstrual blood, straightforward processing, and high yield of menstrual blood-derived mesenchymal stem cells, opportunity for large-scale donor recruitment, and broad autologous and heterologous application. The acellular therapies, the paracrine signaling of the adult stem cells involves secreted cytokines and growth factors that modulate the cell proliferation, inflammation, and tissue repair. Leveraging these paracrine factors in the acellular therapies described herein shifted the paradigm for tissue regeneration. Excluding specific growth factors such as GCSF, PRP is the most widely established acellular therapy for endometrial disorders. So, till now, PRP is an easily obtained blood derivative that, once activated, releases the multiple proteins, growth factors, biomolecules with regenerative properties. Several clinical trials have shown that PRP thickens the endometrium, reduces scarring and adhesions, modulates local inflammation, and increases the pregnancy rate. However, a recent study reported that there was no improvement in live birth rate following PRP treatment. This disparity may have been influenced by the route of administration, substantial differences in the processing techniques, and variance in the patient age or and the comorbidities. These issues may in part be addressed by using allogenic PRP derived from younger sources such as the umbilical cord blood. Bioengineering strategies. The interest in the uterine bioengineering approaches was amplified following the initial therapies reported in 2017, with 60% of the studies published within the last 2 years. Many strategies based on synthetic and natural hydrogels, example collagen or extracellular matrix derived, have emerged using hydrogels as the delivery system for the sustained local release of cells, small molecules, or drugs. Notably, the majority of the in vivo studies employ natural and synthetic hydrogels as carriers for estrogens, stem cells, or apoptotic bodies. On the contrary, clinical trials used synthetic hydrogels alone, often as carriers of biological products. Hydrogel delivery systems have numerous applications in gynecological therapies and merit further investigations. Bioengineering strategies. One of the major limitations of delivering hydrogels from human endometrial extracellular matrix is obtaining the sufficient uterine tissue for mass production of DCM hydrogels. However, given that extracellular matrices are highly conserved across mammalian species, animal tissues specific ECM has the potential to become a valuable resource for biomedical research and clinical applications. For example, a recent study described a novel xenogenic ECM hydrogel derived from porcine heart tissue to treat human infections. So, to conclude, a paradigm of biomedical research has shifted towards developing personalized therapies, combining stem cell based therapies that promote cell renewal and differentiation, acellular therapies that modulate inflammation and promote tissue repair, and biomaterials that concentrate these actions at the target site might be the key for developing future therapies to restore endometrial function and ultimately improving the reproductive success of patients with uterine factor infertility. Based on the existing evidence, cost, accessibility, and availability of the therapies we presented herein, we propose the development of triple hit regenerative strategies, potentially combining the high yield mesenchymal stem cells, example bone marrow mesenchymal stem cells, or umbilical cord, with acellular treatments, PRP possibly integrated in the extracellular matrix hydrogels. These approaches have individually demonstrated their efficacy and have the potential to drastically shift clinical management of endometrial strategies if their synergistic impact is confirmed. Finally, multi-center RCTs are required to evaluate the safety and efficacy of the biotechnological treatments presented throughout this review before they can fully implement it into they are fully implemented into the clinical practice. Thank you.
That was absolutely marvelous. I'm sure we knew something about it, but we did not know in detail so much. And
there is so much. There are so many things which are so new and we are not aware of it, like the hydrogels, how they are used to repair the endometrium, and so many other things like stem cell therapies, the acellular therapies. So I mean, this article was an eye opener for me as well. So many things are happening, and then are we going to use all these things? And when like so many patients come to us with thin endometrium, and I don't know how are we going to use all these things. So definitely, I think if it is there in the papers, then it will be there in the market as well soon.
Right. So it was very, very nice, actually, Dr. Sujata, ma'am. I was just waiting for her to join and for her comments, but I think I can't see her. Maybe I can conclude your beautiful talk, Dr. Laxmi. So as we all now understand after this talk that now we have a three-pronged approach using the cellular, acellular, and the bioengineering part of it, using collectively. We have been using PRP, that is the acellular part, and it has been used because it is autologous. It does not need, it is safe, that is, and it can be easily prepared. So that is why PRP is something that we all have started using, and we are using it effectively, though we still have to come to a conclusion, though the evidence, so because it is still, let's say, it is experimental, and maybe once more and more experiments are being done, maybe one can then get into some proper guidelines can be framed, whether it should be used, how much it is effective, and all that. Stem cells also have been used now very frequently, and there are many studies going on about the mesenchymal stem cells. So as you have told to us that these are three different sort of stem cells where cellular, and the experiments done have been in vitro, in vivo, and that way
clinical
in the clinical senses, then those particular trials, and since they have been used in different, there is still a heterogeneity in these trials that have been done, and that is why more and more trials are still needed. But definitely the bone marrow derived stem cells, we have adipose derived, the umbilical cord, even the Wharton's jelly, the menstrual blood. So there are so many sources that are there. The placenta is a very, so many deliveries are occurring. We have lots of placentas, we have lots of cord blood. So maybe gradually we can start researching how we do it. I don't know. Maybe we have to have some ethics committee formed and then take the approval, and then we can come to some sort of procedure, how we proceed with these sort of preparations, or there will be some commercial preparations coming in which can be used.
Right.
The acellular therapy is our PRP, the same, and the exosome and the microvesicles that you have also suggested, and then the miRNA.
Right.
And the hydrogels are by the bioengineering, which are extracellular matrix derived hydrogels. So these are along these things can be used. We have been using estrogen for the endometrial, promoting the improving the endometrial thickness and the blood flow. We are using a lot of blood flow improving strategies, maybe aspirin, heparin, and all the strategies which can improve the blood flow to our endometrium, to the uterus as such. So along with those, maybe all these strategies can come to a rescue and can improve our results, because this is something we have been struggling to improve our endometrial thickness and the vascularity. And it was so many new insights you have brought. And basically our aim is just to talk about, because maybe otherwise we might not have read such a big article had I, because एक तो हमें लगता है कि हमारे पास टाइम नहीं है, और अगर टाइम भी होता है तो हमें लगता है कि यार एक पेज पढ़ लिया, अभी ये 6-10 पेज 15 पेज कौन पढ़ेगा। अब डॉक्टर लक्ष्मी ने एक अच्छी सी पीपीटी बनाई और हमको सुना दी, तो हम सबको लगा कि यार this was short and sweet and we could go through it, we knew about it, now we can learn more about it. जिसको अच्छा लगा, they can again go read it, and we will put both these articles we'll put in the groups for everyone to read. Whoever is interested, they can even go through the recording also that we'll provide of today's webinar, and also the articles. So thank you, Dr. Laxmi. Then we have another very interesting article being covered by our second speaker, Dr. Rahul Sen. Dr. Rahul Sen is a chief consultant embryologist at Neelkanth IVF, Rajasthan. He is executive committee member of the Academy of Clinical Embryologists, ACE, and he has been nominated as a mentor in the ASHRAE mentorship program. He is the recipient of the ISAR Shining Star Award at Embryology ISAR 2023. And his topic of today's talk is also very, very interesting. The effect of laser-assisted hatching on the vitrified or warmed blastocyst, the ALADDIN RCT. So I have most probably, I think Dr. Charudutt is here.
I'm there.
Yeah, thank you, sir, for joining. Dr. Rahul will just share his, give us his presentation, and then we will take your comments, sir. Over to Dr. Rahul, and thank you.
Thank you so much, Dr. Jyoti, for this wonderful introduction, and thank you, ma'am, for inviting me and to present me this wonderful article, which is basically on laser-assisted hatching, the more renowned or more proclaimed technique, which is basically required, or which basically aims to increase the chances of implantation. Today we'll be discussing about this wonderful article, which is basically related to laser assisted hatching. And this article is basically named as Aladdin trial. And why this is made as in this such name, and what exactly trial is actually meant for. This is all we going to. This is the article. This article, which was published in Fertility and Sterility recently, and let's see what this article has. Its Is there any magic behind it? So let's explore this article. And we all know that during the blastocyst development, blastocyst undergoes various type of developments, and this development causes hydrostatic pressures, which actually leads to the rupture of zona pellucida. And after the zona pellucida is ruptured, then the remaining portion of the embryo gets implanted, invaded, and it actually gets implanted in the endometrium of the uterus. So when we are working under in vitro conditions where we are cryopreserving embryos and blastocysts, it can induce zona hardening. Potentially it can impairs hatching and implantation of the embryo. So there was this technique proposed as assisted hatching, and this assisted hatching was actually aims to enhance implantation in ART, and it involves in creating a controlled rupture or a controlled hole in the zona pellucida that facilitates embryo hatching and attachment. And this Aladdin, as the word Aladdin, this is an acronym which stands for partial zona pellucida removal by assisted hatching of blastocyst. So as you can see in this picture, the partial zona is basically removed from this developing blastocyst, and after this removal of zona pellucida, then the embryos are were being transferred in this study. And this study was conducted at IRCCS Institute in Milan, which aimed to evaluate the efficacy of laser assisted hatching in improving live birth rate with vitrified and warmed blastocyst only. So this technique is not applicable for fresh blastocyst transfer. This is basically aimed only for the cryopreserved blastocyst and later warm and thaw transfers. So this study has included women under the 40 years of age undergoing non-donor IVF cycles with or without ICSI, scheduled for elective single embryo transfer using cryopreserved blastocyst, first and second frozen cycle using vitrified blastocyst after the laser assisted artificial shrinkage was done before the cryopreservation of blastocyst. And what were the exclusion criteria? The patients which were having high BMIs were excluded. Patients which were having uterine abnormalities like adenomyosis, myomas, unoperated hydrosalpinx, even in patients with severe male factor infertility that requires surgical sperm extraction, they were not a part of this study. And even in embryos which were PGT tested, as PGT introduces rupture in zona pellucida, so PGT embryos were not included in this study, they were excluded. The interventions, as IVF the participants underwent standard IVF procedures at their centers. Blastocysts were vitrified using established protocol, and laser was introduced before freezing to shrink to remove the blastocell fluid within the blastocyst, and then the freezing was done. The assisted hatching procedure was randomized. It was randomized in such a way that it was done using Saturn 5 active laser with the diode of 1480 nanometers, with the controlled breach, and it was performed in such a way that it does not assess or it does not impact the developing trophectoderms underneath the zona pellucida. So there was this was the hole created here, and there is again there is a space between the developing trophectoderms, and the laser assisted hatching was done soon after the cryopreservation, soon after the thawing, so that the blastocyst doesn't get expands and it doesn't get contact with zona pellucida. To block the randomization, the patients were employed with with the strategies by recruiting at the centers and with the age group to ensure balanced allocation of participants. Even randomization was concealed until completion of the cycle. Blinding protocols were also included, which was a double-blinded design where personnels involved in patient care and outcome assessment remained unaware till the allocation was done, and it was blinded up to the laboratory personnel as well, which were handling and randomizing the treatment assignments. The whole trial was aiming for these two outcomes, which were the primary and the secondary. The primary outcome is the rate of live birth rate after the the inclusion of laser assisted hatching, and it was defined as the number of deliveries resulting in the live birth rate per randomized blastocyst transfer. And secondary endpoints of the study were clinical pregnancy rate, miscarriage rate, multiple pregnancy rate, obstetricals, and neonatal complications. Even the blasto even a criteria was also mentioned. While the blastocysts were graded as per the Istanbul Consensus 2011 before going for embryo transfer, and quality was assessed just before the transfer. Statistical analysis. The primary outcomes analysis involved calculations as per the risk with 95% confidence as compared to the live birth rate with the assisted hatching and the control group. Statistical significance tested using Cochrane Mental Hansel test, adjusting the stratification variable, and the software was used was SPSS utilized for the analysis. The summary, the trial, this summarized as initially they have screened 2000 more than 2000 participants, and ultimately it ended up in including 698 patients after exclusions and randomization error. Baseline characteristics were balanced in both the groups, assisted hatching group and the control group. There was no primary outcome difference, like the no statistically significant difference was seen in live birth rate as observed between assisted hatching group, which was 29.8%, and in the control group, which was just a slight lower, but it was not a significant difference, but it was 29.2% only. And secondary outcomes also measured as similar rates of clinical pregnancy, miscarriage, and neonatal outcomes between both the groups were same, and it ultimately ended in suggesting that assisted hatching did not impact these outcomes significantly, these secondary outcomes significantly. And when the same study, the same trial, which it was when it was compared with other studies, it also proposed as the study which was done by Debrock et al. In 2011, and which was an RCT of 647 thawing cycles, and it also concluded that no improvement with quarter laser assisted zona thinning, where few studies were also found a positive impact in terms of assisted hatching. It was done by Van et al., and there was again a large prospective trial which included 4,063 participants, which ultimately ended in concluding it have shown increased live birth after the complete zona removal or the quarter zona removal, even in poor quality transfers or in poor low grade embryo transfer cycles. So to summarize this, there are mixed results due to the design, patient selection, and the assisted hatching techniques. It also emphasizes the need of RCTs in assisted hatching efficacy and in safety of frozen blastocyst transfers. This trial basically has plausibility with the discussion with the cryopreservation strategies that basically induces zona hardening, and it can be a potential implication for in frozen thaw blastocyst transfers, even in subgroup analysis trends suggesting that potential benefits of assisted hatching in specific patient groups like advanced maternal age, conventional IVF cycles, in top quality blastocyst transfer that still warrants further investigations. And there is basically, yes, there is a need for exploring more alternative protocols other than laser assisted hatching that refines patient selection criteria based on the observed trend and subgroup analysis. So the study has few strengths and the limitations. As a part of strengths, it is basically a trial design reflecting the real world actual current scenario of clinical practices, large sample size with sufficient statistical power, and it has comprehensive data collection and adherence to at least standardized protocol. The limitations are like why they have excluded older and overweight patients. This was the major limitations. Procedural factors such as laser artificial shrinkage using before the laser assisted hatching for embryo transfer, why this artificial shrinkage was used before freezing. Study also powered to detect a minimum of 10% difference in live birth rates, smaller clinical difference but may require large sample size, lack of blinding embryologist involved in the study procedure. To finally conclude, the key findings are laser assisted hatching, yes, did not significantly improve live birth rate in frozen embryo transfer compared to the control group. The recommendation, as a part of recommendation, it can be recommended in routine assisted hatching based on current evidence. It also requires further well designed studies. The insights of clinical decision making and patient counseling strategies is very well required. In the near future, we can expect there may be an urgency of exploring other techniques also with the same selection criteria and with the same subgroup analysis and emerging evidences also. Thank you so much. Thank you.
Thank you. Thank you, Dr. Rahul. It was wonderful, very crisp, very short, and very clear, actually. Personally, I would like to ask you whether you have been using the laser hatching, and what are your personal views about it, apart from the trial that we have seen that they still do not suggest. They say the pregnancy rates and the implantation rates are still the same, and though they need further studies, and that why this shrinkage was done and why it was not done in
Yes.
obese, why the obese were excluded. So that is,
Yes.
I mean, whether obesity and what connection it has got. So that is a little difficult to understand. So your comments on that, and whether you personally have been using laser hatching, and how what are your personal views about the whole thing?
Yes. First talking about the artificial shrinkage, generally blastocyst, within the blastocyst, there is a fluid-filled cavity that is the blastocele. So the aim is to reduce the water content. What we do in cryopreservation is we reduce as much as of water just to avoid any kind of intracellular ice formation. So this strategy is very well documented in literature. They may use laser assisted hatching, they may use with the injection needle by sucking out the blastocele fluid. So it is basically a strategy to completely remove the fluid from the blastocyst before cryopreservation. So nowadays, what we see in our routine practice is the protocols for cryopreservation are very well designed. The cryopreservation media is very well formulated. So nowadays, it is not as much that required to remove the blastocele fluid before the cryopreservation. So we can take the blastocyst directly into the media for cryopreservation, and we can freeze it and thaw it and then do the transfer. So this is the one point for the artificial shrinkage. And another thing is, yes, we are using laser assisted hatching in our routine practices, but in general, laser assisted hatching, we are restricted to few of the patients only, and in few of the conditions only, like when we are doing a frozen thaw day 3 embryo transfer. So just to reduce the hardening content of zona, because after the cryopreservation the zona gets loosen up or the harden up, so it basically gets acclimatized with the endometrium when it is being transferred, because day 3 embryos, they remain for 2 days within the uterus before implantation. So it can actually help in aiding, or it can actually help in aiming the implantation. And in other subgroups, like when we have a thick zona over the blastocyst also, in those cases we can aim for laser assisted hatching, or in patients which are having or which have seen previous implantation failures. So in those cases, laser hatching can be a fruitful cause. But using for all patients, I think that might not be a fruitful thing. We might end up in damaging blastocyst. We might up ending in losing the blastocyst component while transferring, because at times we can see the whole zona is basically broken, and the blastocyst comes out while doing laser assisted hatching or while handling the embryo during the transfers. So it is basically it should be standardized. It should be standardized with the embryologist. It should be standardized with the intensity of the blastocyst, the intensity of the diode laser to be used. So yes, the technique has its pros and cons, but it should be limited, not for all.
Dr. Charu sir, now your comments. I think you were busy, but you were still listening to us.
Yes, yes. See, this laser, I have seen this laser from last so many years. I have used it personally. I fully agree with Rahul. See, practically, whenever a new thing comes up, it takes some time to get established, and then with the proper outcome and reports, and then only we should be able to adopt it. So with laser initially introduced, there were so many problems with it. The cost was involved and the use of it. Then there is no much power is there who knows exactly what kind of laser this is and all. So slowly it come, but still I feel that it has its limited use. It cannot be used for everyone. Yes, of course, like the cases where previous fertilization failure, or in case of your embryo transplant is not done, 2-3 cycles already done, in that case you can offer this. Even in frozen cycle also, as Rahul rightly said, right now no one is offering this laser with the, but this is one of the common use. Was the common use when laser come in picture, that the frozen thaw cycle, you first rupture the zona and then you transfer. Probably it will help you in getting better implantation. There were few paper also which was published and they have shown slightly improvement. But ultimately, it is at the end of the day, the overall, if you see, there is not much difference in the normal one as well as in the laser assisted hatching one. yes, nowadays like biopsy is becoming common. So for procedure like biopsy, you need such sophisticated instrument which will help you out because doing mechanical biopsy, mechanical degeneration of zona or by enzymatic degeneration of zona, it may cause problem with the embryo, it may damage embryo. But with laser, you have very precision shot and you can take it. But as it's rightly said, all things have its pros and cons. So as far as my opinion is concerned, I am also of this opinion that this should be a limited use tool. It cannot be offered to everyone. Yes, of course, in today's era of marketing and gimmick, this is one of the tool which attract people. Like we have laser also, but the use of laser actually is very limited. It
Yes.
cannot be used for everyone.
Yes. I completely agree, sir. Yes.
Actually, so that is why we always keep you in our discussions, sir, so that we can get the genuine view about the rather than the gimmicks. I mean, it is not a gimmick though. It is for certain cases. It does
No,
really.
no, definitely. See, madam, whenever new thing comes up in market, definitely it is come up with some background, some research. It's not like they come up all of a sudden with something and like nowadays we are listening about automatic vitrification. There is a machine which is already in system. Now, from yesterday, I am constantly thinking what I will be going to do if the machine is replacing the vitrification. If the machine will do vitrification, what we will do? So, but exactly it is not like that. It depends on right now it is just introduced. Let's see what is its implication, how it is used, what is the cost and all, and then probably it may give an answer to our questions. And particularly where the large number of cycles are done, like at Rahul's place where they do quite a lot number of cycles, there maybe it is of a practical use, but the small centers where they are doing monthly 4-5 cases or 3-4 cases, it's my say on this that the laser has its limited use. It cannot be used for everyone. That is for sure.
Right,
And
sir.
and even after a decade of being laser introduced in the market, this laser has also a learning curve. Means embryologists, clinicians, and IVF specialists, they needs to adapt this strategy. They need to learn how this laser is going to function and where it is going to function. So that is more important. So I completely agree with Charu sir. Yes.
Right. So that was indeed a very clear insight, Dr. Rahul, about whether the role of laser, their uses, when to use, and whether really it helps these trials actually guide us so many things. And some, because sometimes we might be just thinking, oh, we don't have a laser in our center, should we add it? But maybe when we see that the results are not so drastically different, and such big trials, the Aladdin trial, they have more than 6,000 people were this thing included in the trial. So these things let us get the real idea about the whole research and about the whole technology. So it was very nice, and thank you for accepting our offer to present.
Thank you so much.
Actually,
It was wonderful.
this in our up to dates, I forgot to tell that we have one of our Haryana speaker, and one speaker we take from ISAR, National ISAR. From we have a list of the youngsters from the team of National ISAR, and sometimes we take at least one person from the Young Turk of National ISAR. So that is how, when we thought that it was a embryology article, I thought of asking you whether you could be
Yes.
able to present it. And thank you so much for joining and presenting. And thank you, Dr. Charu sir, for joining and for your expert comments. And tomorrow
Thank
again, we have a 25th is the IVF day and also World Embryologist Day, but we would be celebrating it on 24 tomorrow on a web platform where we would again meet. We'll have a good discussion with many embryologists from 3 to 4. I'll send the link And we meet again. And thank you, Dr. Laxmi, for a nice presentation. Thank you, Dr. Deepika, for the platform. And thank you, Jackson Paul. Thank you, all the people who joined us and because if you join, we also feel very happy that at least our efforts are being rewarded. We can share the recording as soon as it is available to us. So thank you and keep safe and stay happy till we meet again. Thank you.